Welcome to Zoom. Enter your meeting ID. You entered 16. This meeting ID does not exist. Please re-enter your meeting ID followed by pound. Enter your participant ID followed by pound. Otherwise, you are in the meeting now. There are 1 participants in the meeting. This meeting is being recorded.
Our goal is that by the end, we'll have some shared understanding of risk reduction or harm reduction, who's at risk, some specific evidence-based harm reduction interventions for opiate use disorders, and how to incorporate some overdose prevention into primary care practice. So what is risk management or harm reduction? What we're really talking about is how to take measures to reduce the likelihood of a bad outcome or a loss, or reduce the severity of a loss. So something like installing a security system, using seat belts, airbags. As you can imagine, these things help if you get into an accident, they stop you from being hurt as badly, or maybe they deter something from, the security system might stop someone from breaking into your house. So principles of risk reduction when we're thinking about opiate use disorders, there are some people who have some risky use of opioids or have an opiate use disorder, and they're not ready, willing, or able to stop using right now. Oftentimes, we know that the use can have negative consequences for the individual. That's part of our definition of a substance use disorder. And it can have negative consequences for their families, for their community, or for society as a whole. So what are the things that we can do to reduce the most harmful aspects of drug use? The harm reduction organization has some wonderful people who are local. I think some of you met folks at at the rally in the Valley, right, from harm reduction. Harm reduction, their definition, they say, is a set of practical strategies and ideas aimed at reducing negative consequences associated with substance use. Harm reduction is also a movement, and this part I think is key. We're all sort of part of that movement right now. It's a movement for social justice that's built on a belief in and respect for the rights of people who use substances. So some of the risk reduction strategies that we'll talk about today, some of them are easier to put into practice than others. Some of them we need a movement and we need each other to stay accountable to. One is to reduce the stigma and prejudice surrounding disease. Another we'll talk about is increasing access to evidence-based treatment. I think all of us know that some of what we do is based on real evidence and some may not be. Teach safer injection practices and safer use. Things like not using alone, so that if something does happen, there's someone there to help you. Sticking with a single dealer, doing a test shot, using aseptic techniques. These are preventing a variety of different possible bad outcomes, from overdose to infections. Some other ones that we don't have access to locally is provide access to needle and syringe exchanges, but I'd be interested in some lively discussion about that. Consider implementing safe injection sites, and then increasing access to Naloxone for overdose prevention. I want to stop for a second and see what are some other sort of risk reduction or harm reduction strategies that you guys use. Go ahead and chime in.
One of the things we do at Mars is actually provide our higher risk assessments when they're waiting a bed with naloxone, as well as instructions on how to use it.
Awesome. What else are people doing for harm reduction?
So in addition to prescribing naloxone and or giving a kit to individuals or to families of individuals who are at risk, if opioids are being prescribed to a patient that we're seeing, we talk about and try to provide access to naloxone, but also talk about how to dispose of unused medications and how to keep those medications out of the hands of vulnerable individuals, anyone from toddlers to teenagers who may be experimenting with medications in a medicine cabinet, to older adults who could get confused about medications. And really we're trying to standardize those instructions across our network so that if an opioid is prescribed, say after a surgery, that there are standard instructions that are included with that opioid that include all of those pieces.
Awesome. And as you think of more of them, just keep them in mind and we can talk about them, especially during the cases and so on. I'm going to say now that some of these slides are 2 years old, so there's probably some updated information, and anyone who wants to chime in on that, please do. But as we know, opioid overdoses are a huge problem. And despite many very innovative and wonderful things that are starting up in our community across the state and across the country, there's still a lot of people who are dying of overdoses all across the age ranges. We see teenagers who are dying of prescription opioid overdoses, older folks 65 and above, who may have unrecognized substance use disorders or polypharmacy. People are really having a tough time and struggling with prescription opioid overdoses as well as the illicit drug use. Some risk factors. I know that you guys know this stuff inside and out, but higher doses, so over 100 milligram equivalents, morphine equivalents a day. Recent releases from controlled environments, people who have been incarcerated or people who've been in inpatient treatment. We know that some of the releases are quick and maybe don't have the most careful connections planned out, so the risk of overdose after incarceration or recent inpatient treatment is particularly high. Release after emergency care for overdose. Phil recently read an article about this one, right? And I think that Jillian could probably talk to us quite a bit about what are the risks after somebody leaves and what have they been doing at LVHN to try and change that risk. Mixing opioids with benzos, alcohol, and other drugs. And then medical conditions. People with lots of medical conditions may be more fragile. Renal, hepatic, pulmonary, HIV. And this, as Lynn will tell us, would increase the risk, particularly for our older folks. The interesting questions are, where are the prescription pain medicines coming from, and where are most of the non-medical use reported for past users who are age 12 and older? This is older information, but I'm not sure that this has actually changed all that much. This is of the medications that have been diverted and are used non-medically, where did they come from? And a large amount of it, huge, is from friends or relatives. Some people will buy it on the street. We've heard lots and lots of reports that everybody knows where they can get some Percocet. Some from drug dealers, but often from friends or other folks. some from more than one doctor, you can see up on the top, that those are the folks that that receive that label of doctor shopping, but it may not even be particularly intentional. One doctor bought on the internet, that actually exists. Things I don't know how to do, but other people do, right? So lots and lots of sources of where do people get their prescription pain medications. And there we go. So we know that back in the day, the drug companies were telling us that there are abuse deterrent formulations or abuse resistant formulations, some of the longer acting opioids, or the partial agonists, oxycodone, etc. There are currently no proven abuse deterrent or resistant opioids or formulations. People have tried using physical barriers of how you put the medication together, the agonist-antagonist combinations, putting the naloxone in there. All of these different things have been tried. There's a lot of effort from the drug companies to figure out how to decrease the harm of prescription opioids, and none of it has actually worked. So what else could we do? Some things that we can do to sort of decrease the diversion is the prescription drug monitoring programs. I think all of us have been really grateful, prescribers, to have this resource available. Some of the difficulties are that sometimes people don't use the prescription drug monitoring program. Some people still don't exactly know how it works, but they can really help us to focus our attention on what might be going on in the community, understand a little bit more about the trends in demand. And there has been some evidence that this works well in communities. But what we see when there's less supply of the prescribed medications, then we see more people shifting from prescription opioids to heroin or to fentanyl. Some increases in the injection drug use, and some more unresolved problems of still having trouble getting to treatment. Oops, I just slipped through that one. The risk reduction attempts have lowered some of the availabilities, but lots of misuse still available. And then we see that the uptick of the red line there with the little squares, that the heroin use and fentanyl use have been going up. So these are great ideas to try and help those who are prescribing opioids do it in a more responsible way, but there are unintended consequences as well. Most notably, the enormous increase in the availability of fentanyl, and in our communities that has been really devastating. Jillian, do you have a sense of what percentage of the overdoses that you're seeing in the tox department have fentanyl in them?
So it's tough because the point of care testing does not pick up on fentanyl. So there has to be a very kind of a concerted effort to send for confirmatory testing to pick that up. So we don't have great data from our ED patients because a number of them don't end up getting those urines sent out. But from data outside our hospital, we know that probably about 90% of the quote heroin supply contains at least one fentanyl or fentanyl analog, and is the vast majority of the time a combination of multiple opioids. So I think it's safe to assume that probably the vast majority of our overdose patients have suffered from a fentanyl or similar synthetic overdose.
one of the interesting things here is that we see that when we think about accidental deaths or injury deaths, so somebody needs to go back and mute. Richie, can you mute everybody? Or Star? Okay, what I need for everybody to mute their phone or their computer so that we can diminish that echo. Are we good? Can you still hear me? Good. All right. We've had lots of harm reduction efforts as far as motor vehicle accidents. We talked about some of those in the beginning: seat belts, safety features, airbags, and we see that the deaths have been decreasing. But for our drug poisoning, the rates have been going up. Let's see. All right, let's look at the PDMP. We're a PDMP state. Can you think about some reasons why a state might not have a PDMP or the Prescription Drug Monitoring Program? Anybody have an idea? Now that I've asked you all to mute.
Lack of legislative gumption.
Gumption. Mm-hmm. Was anybody that's on the call involved in the efforts to get the PDMP passed for Pennsylvania? Were you aware of any of the barriers locally for us? I'm not one of those people, but I know that we were not one of the early adopter states. It took a while for this to happen. I think that consumption is a multifactorial event, right?
Is cost an issue?
I think cost can be an issue. You need some infrastructure to get it done. So somebody has to allocate the expense somewhere. I think luckily it became sort of evident that one bipartisan event is that people would like to see fewer overdose deaths. So there has been able to be some success in places that don't necessarily break down by red and blue states, as you can see here. This is old, so there are more states that have joined in since then. And one of the things that I think is really exciting about the PDMP in Pennsylvania is that you can check in on other states as well. And that was a relatively new feature, so that we can see across some of our territory boundaries.
Abby, I thought every state had the PDMP now.
I think they don't. Am I wrong? I thought there were still 4 or 5 that didn't.
I thought every state did, but I'll double check.
Maybe true. Okay. So those are some sort of larger structural ideas about what can we do for some harm reduction. what are some of the things that we can do in primary care teams? One is using the CDC guidelines for responsible opioid prescribing. This is something that the Stewardship Committee and Linkage to Treatment has worked really hard on. Shout out to Kevin. We will have a portion of a session where we'll go into this in more detail. But the basic idea is to take a more holistic view of pain management in general. Use non-opioid therapies when you can. If you are using opioids, start low and go slow, and use lots of close follow-up, including using risk stratification tools, and I think doing a lot more education than we did in the past to identify substance use disorders in people who are being treated for pain with opioids. Kevin, anything that you do want to add in there that's essential in the very short version?
Yeah, just we do the protocol that was developed here in the network really adheres to the CDC guidelines. So it's all about risk assessment at the outset, and then ongoing risk assessment and mitigation. So everything you mentioned, the PDP, the integration, all the risk assessment tools, the drug screening, the use of LVHN approved controlled substance agreement and informed consent. So that's what we're trying to do. And I think in terms of, we're following it with our process metrics, and I think that we've been making some improvement in that regard. And the PDP integration with the EHR caused a dramatic increase in checking the PDP. So that was good to see.
That's really cool. My research associate here says that every state except Missouri has a PDP, but does include Guam.
Thanks.
Then we can shift over to preventing overdoses. What can we do in primary care for overdose prevention? I don't know if everybody's ever had a chance to look at the SAMHSA toolkit. It's got some great, easy things to implement at the office level, especially for anybody that's prescribing opioids. But here briefly, we can go over the strategies. Strategy 1, encourage providers, persons at high risk, family members, and others learn how to prevent and manage opioid overdoses. And that would involve primarily Narcan or Naloxone, getting that out to people, training them how to use it. But I think getting the prescription out in and of itself isn't enough. People do need to know what to do and think a little bit about their own risk situations and who's the ally that's going to help them with that. So some good education for people about how to do that. Strategy number 2, access to treatment for people who are misusing or have a substance use disorder. We know access to treatment's complicated in our communities. What can we do to innovate and work together? And that's part of the point of our ECHO here, is to put our heads together and think about how do we streamline access to treatment for people. Ready access to Naloxone. We know that in Pennsylvania, we've got the standing order for Naloxone, so anybody should be able to go to their pharmacy and pick up a prescription, but there are still barriers to that, including cost and some pharmacies at expense. Strategy number 4, encouraging people to call 911. If somebody has an opioid overdose, that even if you have Narcan at home, that's short acting, and call 911. We had a patient actually a while ago who was really struggling, that a friend of hers let another friend die because she didn't know what to do, and was trying to think through for herself, what do I need to do as someone who's still involved in the community of people who are actively using, to get the word out that you have to call 911. That was what had been the fail in this case. They took too long to call 911 because they were confused and scared and didn't know what to do. And preparing people for all the emotions that come up, as well as just, how do you do the steps use some naloxone, call 911. And then encouraging the prescribers to use the PDMP. Anybody have anything else that they think is essential for overdose prevention? Something that they've started to do that they feel is making a difference?
Well, I think the the outreach, what we've tried to do is remind prescribers and the office that if there's comorbidities at a dose of 50 morphine equivalents, and certainly 90 or higher, to just routinely recommend naloxone. And then the pain management site does have a guide, including videos, to show to family and patients on how to use naloxone.
Mm-hmm. Great. Thanks, Kevin.
We've had, we've had several opiate users in the transitional care unit that I'm in. They're there in long-term rehab, basically, and we're doing our best to provide significant education that if they do continue to use opiates outside of the TCU, that their tolerance or their ability to handle that dosage is probably going to be, that they used to take, is going to be much less. So we try to get them, to services, but we also have to give them education that if they're going to use again, they have to be very careful, because they could have a significant overdose, even if it's the same doses they took before they came into the hospital.
Mm. Wow. Okay. I think that our group here, we're pretty well versed in some of these things, but we can just look really quickly. An overdose is when somebody's not breathing, small pupils, blue lips, blue fingertips, not breathing, not responsive. Make sure the scene's safe, call 911, do your rescue breathing, give naloxone, right? Yep. Making sure that people have access to treatment. We know that access to treatment can help people get to recovery and reduce the risk of overdose. And when we look at the community level data to see where there's more access to treatment, what kind of outcomes are there, we see reduced infections, reduced criminality, improved self-care, social functioning, that at the individual and the community level, access to treatment is a positive, good thing. I think part of what's difficult is that sometimes people don't know where or how to get into treatment. And one of the barriers that we're hoping to reduce is the barrier to medication-assisted treatment, either methadone or buprenorphine, or naltrexone, and most importantly, the access to counseling and other support services. I think what we're working toward locally is if there's more access to the medication-assisted treatment, then that may reduce the pressure on the inpatient beds. But we want to see that happening with the counseling and the medication-assisted treatment together. Because without the counseling, the buprenorphine is just treating cravings and withdrawal symptoms. Anybody have anything that they want to comment about that? Bless you.
I have a question.
Sure.
When in the last couple years that you've focused on the opiate use disorder in the Valley, have you seen an increase in prescribers that would be interested? I mean, I know that we have a few obviously today that we're speaking to, but just an increase available that they would be willing to, contract with other agencies or refer and work along, not only with Pyramid or Treatment Trends or NHCLV.
I think that's a great question, Yamalisa, and I think there are a lot of barriers for regular primary care practices getting involved.
Mm-hmm.
And we're hoping that with the ECHO that will help show that these are things that an office can do with the right kind of support. And how do we work with the health systems to sort of provide the other supports that a practice might need. So the real answer is that there's interest, but not action.
Okay.
So far. And I think, you know, all of the programs that have been built to try and make this kind of integrated system that are using the medication-assisted treatment in conjunction with counseling, trying to do this the right way, all of them have been designed around this idea of a hub and spoke model, that there's a hub in the middle that will help kind of bring people into treatment, coordinate that care so that they are getting access to what they need for recovery. And then the spokes would be those primary care practices out there who can take back the patients who are a little bit more settled and on track toward recovery. And we don't have those spokes. So we have to build the spokes. And hopefully this ECHO will help us to move in that direction.
Great. Thank you.
Mm-hmm. And while we're sort of looking at these, this is the information that's in these sort of pre-packaged sessions from the previous HRSA ECHO for the community health centers, these ones that we're looking at. This is what a group of experts sort of around the country thought was essential information for primary care practices to start getting involved. So it's interesting to look at it from that point of view too, and see, you know, what is it that will help the clinicians in those practices and the practices in part of larger networks. What gives them, I'll use your word, gumption to get going and start doing this work. So we'll just go through our strategies a little bit quicker. Access to naloxone. We know that it works within minutes, lasts for half hour to an hour, a little more. And that it's been approved, and with that standing order at the state level, there's there's sort of no liability for administering it to somebody. We've been writing prescriptions for the intranasal. I tend to put refills on that and encourage people to refill as often as they can. Have a lot of naloxone out there. At NHCLV, we're prescribing naloxone for anybody that's on medication-assisted treatment, anybody that comes to us and is diagnosed with an opiate use disorder, and anybody that's on opioids for pain, as well as anybody who is talking about family situations or being in a community where they're at risk. Anybody doing anything differently? And the other good news is that there are lots of other naloxone distribution plans out there. The first responders are providing lots of naloxone. I think the Blue Angels program that goes out after overdoses is bringing naloxone to people's homes as well. So everything that we can think of how do you get more of this into the community, and some education around it about how to use it effectively.
Abby, could you talk just a little bit more about cost and whether or not that's a barrier, and if it is, how to overcome that?
Yeah, this is another one that I think is a little bit confusing. These should be covered by insurance, including Medicaid. You should be able to go to any pharmacy with or without a prescription and have it covered by your insurance. So at a policy level, I think that the state has set out a policy that does its best to reduce the barriers of cost, but we do hear some reports from some of our patients of pretty high copays, up to about $70. I don't know whether that's because it's commercial insurance and whether it's because it was a prescription for the brand Narcan. And then there are some pharmacies that aren't entirely in compliance with the standing order. So I don't know exactly what's going on there. I know that when the Bethlehem Health Bureau did a survey a couple of years ago of pharmacies, there were a number of the smaller pharmacies that were 2 years ago still weren't aware that there was a standing order, and a few that were aware but weren't intending to comply with it, and that some of the larger pharmacies, that they were sort of your safest bet. But I don't know, what are you hearing, Kevin, out there? About cost barriers?
Looks like a message popped up that it said he popped off, so I don't know if you had a tech issue. Oh, there he is. He's back.
Okay. All right. Okay, well, we'll circle back to that one, but the cost barriers by policy have been addressed, and yet individuals are still reporting that they're having some cost barriers. So anybody else have any experience with people saying the naloxone is too expensive?
I mean, my understanding is that, at least according to our colleagues at CVS, the pharmacists there, is that you need to say that it's for you. So if you go in and you say, I would like Narcan for my son, you'll probably have to pay out of pocket. But if you say I have insurance or I have Medicaid or whatever it might be, and this is Narcan for my use, then that's the buzzword that the pharmacist needs to hear to be able to put it in as, to get it through your insurance, and then it should be covered. I don't know if that's true, but that's what we were told.
That's interesting. We'll look into that. Another question from a research associate over here. Okay.
Abby, my experience has also been that patients with private insurance have had very high copays when trying to access their Narcan script, even for their own use.
And are those copays any different from the usual copays on their insurance?
I don't think so,
Right.
but it's definitely a barrier to getting access to the medicine for harm reduction. When your MS Contin costs you $15 and your Narcan costs you $75, chances are really good that you're not getting it.
Chances are. And who was our other comment?
Oh, I was just curious, is it limited to one Narcan, spray per prescription? Can you get more than one? People that are using heavily or carfentanil or fentanyl, do they get more than one, or how does that work?
I don't think that's actually addressed in the standing order, but we can take a look at that. Most, the intranasal comes in a box of 2, and I tend to put it on as a 7-day use and 3 or 4 refills. But I haven't really heard back from people whether they have trouble picking up another one. Great questions to ask. I think we'll be asking at our next MAT session and see what people think about the Narcan and whether they picked it up and what kind of barriers they found, and I'll get back to you with our next echo. Okay, so when we look at office setting for addressing opiate use disorders and harm reduction, what we're talking about is, even if your office as a primary care clinician isn't ready to provide medication-assisted treatment, these are still things that you can do. You can still offer patient-centered care, and we'll talk a little bit more about decreasing stigma. You can consider offering medication treatment to any patient with an opiate use disorder. I think one of our messages to the primary care practices is that you don't need to do this and see 100 patients. You can do this with a patient that that's already somebody that that you diagnose with a substance use disorder. So if we have more people out there with their X waivers, this is a useful tool in your everyday practice. We want to consider other sort of unconventional treatment sites. I think that what they're getting at with this one includes some of the safe injection sites or needle exchanges. How do we provide care in partnership with some of those places. What kind of counseling can be provided, in a office setting if we have integrated behavioral health, and how do we keep our treatment goals a little bit flexible, so that we can continue to use a harm reduction approach. One of the things that our team at neighborhood health centers has found to be the most useful is establishing collaborative relationships with everybody who might have something to offer, to build an integrated system and to offer care for our patients across the spectrum of their needs. So have relationships with the methadone treatment providers, with the detox programs, with the inpatient rehab, and with our outpatient drug and alcohol counseling friends. That without these folks, our primary care office would not succeed. And we've been really lucky and grateful that all of the partners out there in the community have been interested in learning about what could primary care have to offer in a system, and how do we work together and keep track of our patients together. I mentioned integrating primary and behavioral health care. This is something that primary care practices often have a goal to do. It's a little harder to do than we might think, but in primary care, we know that the mental health issues are there in our patient population, and when we're using a patient-centered approach, we need to be able to identify and address both the physical health and the behavioral health issues. So how do we bring those resources into or near our offices so that we can coordinate care well? And I think the last approach that's listed here about recovery-oriented support services, particularly peer mentoring, that there's more availability now than there was a few years ago for certified recovery specialists and other peer support. How do we help people navigate to those kinds of programs so that they can hear the message from a credible messenger that maybe understands their situation better than I do? So one of our goals for the Project ECHO is to bring people together so that this reaching out into your community to facilitate engagement, that we're doing that together already. How do we come together around the ideas of harm reduction and trauma-informed care to help these primary care practices take an active role? How do we communicate with those peer counselors? How do you find the agencies that have different things to offer? I think it's often really tempting for us to think in the medical world that if we're going to do something, we ought to be in charge of it. But how do we do something in partnership instead, and let the organizations that have been doing this for years and years and do it really well show us how to partner with them? And then some of the other ideas that the ECHO group is putting out there is really look to and support some of the other kinds of programs like that help us find the most at-risk populations, like syringe exchanges. We know that here that's not something that any organization has exactly taken on, but if we think about our street medicine programs and some of the other outreach programs out there that are offering some services to people who are actively using, how do we partner with them to figure out who needs help and be able to provide some outreach and education through those venues? So in summary, we can, in primary care, help patients stay safe, even if they're not motivated or able to stop using. And that is a statement that's true whether we're talking about primary care or some of the other drug and alcohol programs, and particularly some of our other behavioral health. And I'm thinking about our Marikey friends for the wellness programs. That there are ways for us to engage in safer opioid prescribing using the PDMP and being responsible to make sure that we're not providing supply for diversion, and that there are a lot of harm reduction ideas out there that we have yet to really fully implement in our community. Whether we're talking about the syringe exchanges, we're doing, I think, a lot better when we're talking about the Narcan and getting that out for people, or Naloxone, to help reduce the harms for people who are using drugs. Bill, do you want to say anything about what you just discovered about the Narcan and the standing order?
I was just reading the standing order from the state. It says that the standing order is eligible for those at risk of opioid-related overdose, also family members, friends, or others in a position to assist, but is not for those who are employed by a health system or people that have access to a prescription writer. And it doesn't say anything about it being required to be covered by insurance, just that it's required to be available to those that don't have access to a prescription writer, and that people should check with their carrier.
That's really interesting. So if we're talking about someone at risk, or family or friends or others, that really does sort of suggest that everybody. So it's interesting, Jillian, that what you were hearing about people have to say it's for them, that is not actually in compliance with the standing order.
It says explicitly that eligibility includes family, friends, or others in a position to assist.
Mm-hmm. Interesting.
Yeah, it is. I mean, I don't think insurance companies are cooperating with that standing order.
Yeah.
You know, they're willing to cover for their own patient, but it wouldn't be for the betterment of the community, or to, you know, increase safety in the home or in the community, which is unfortunate.
Right, and it may be then that that a possible course for some advocacy would be to hold those insurance carriers accountable, that the standing order actually says for anyone. But again, it isn't requiring them to actually cover it. So interesting, right? Some references, we'll be posting this up on the website. Anybody have any other interesting comments or thoughts about the harm reduction?
Abby, I've been thinking about this a lot lately, and I think that I feel very strongly, actually, that we should have syringe exchange services in our communities here. I recently joined Pennsylvania Harm Reduction Coalition just to learn more. It's run by Devin Reeves, who I met at the Schuylkill Drug Recovery Day, or recovery event. And I feel like I'm learning a lot just by speaking with him, and then a group of us, including some of our street medicine providers at LVHN, went down to Prevention Point in Philadelphia to learn more about what they do. And a couple people from our county, drug and alcohol, went as well. Joe Martolucci came with us. So we have a lot of barriers here. Our district attorney's office is opposed to doing this. Obviously, it's federally illegal to provide a syringe. Syringes can be prescribed for, prescribed drug use, but cannot be dispensed for illicit drug use. But I think it's narrow-minded of law enforcement to disallow syringe exchange, and my life goal is to get syringe exchange going in our community. It's obviously not a complete solution to the problem. It's one approach that can be used in addition to all of these other approaches that we've been talking about today. But we know that 1 in 3 injection drug using individuals has Hep C and doesn't know it. And 1 in 3 EMS personnel will be stuck by a needle during their career. And that we know that syringe exchange does not increase use in any way, and actually reduces HIV, Hep C, as well as the spread of serious bacterial infections like endocarditis, and also wound infection. And so I think we have a long way to go in our communities, and I've started conversations with the district attorney's office. And my first conversation has been that we're trying to map, along with our community health folks at LVHN, trying to create heat maps of overdose deaths, individuals who are seen by the Blue Guardian program, who visits people who have been reversed with Narcan by law enforcement, and then our host referrals to the county and Hep C data to see where in our area, and I'm guessing downtown Allentown, probably Bethlehem, will be hotspots where harm reduction interventions might be of great value. And I think the first step from my standpoint to overcome those barriers is going to be to look at data and to show how important it is to consider a multi-pronged approach that includes something like syringe exchange services, which can be bundled with point of care HIV, Hep C testing, wound care supplies, antibiotics, linkage to MAT and Hep C and HIV treatments, behavioral health services. There are so many services that can be provided if we use syringe exchange as a touch point. So that's my 2 cents. I'm hoping that to find partners in the community who are interested in learning more about this. And we've begun to sit down at coffee shops to talk about it. But for now, it has to stay out of our hospital system because it's federally illegal. So I am personally looking for partnerships in our community to see who else is interested in thinking about this and figuring out how we might be able to improve what we're doing with harm reduction beyond naloxone and drug take-back.
Mm-hmm. Sarah, what are the conversations around needle exchange in Schuylkill County? Are there any conversations happening that you know of?
Not that I'm aware of. Obviously, the concept has been out there, but I'm not aware of any conversations that are actively going on involving it.
Mm-hmm. In Reading and Berks County, do you have needle exchange in Reading?
No, not that I'm aware of out here.
Mm-hmm. I've heard Devin speak also from the Harm Reduction Coalition, and it's really a compelling case. Interesting to think about. I think they've been going to Lancaster, but not Reading. It's kind of interesting.
Jillian, I could invite you to the next Heroin Task Force meeting at the Health Bureau in Bethlehem. And they actually do discuss needle sharing sites, and they have a program that is identifying some of the data that you were looking for.
That would be great. Yeah, I've reached out to them before. I think one of our docs, Rob Cannon, is on that. So I think he's been sort of representing there. I reached out, and then I really never heard back. I don't know if it's because there's probably already one of us representing, but I appreciate that. I would be really interested in hearing what those conversations are.
And Jillian,
Thank you.
issue locally also, is it still mainly lack of support from the DA offices in the counties?
Yeah, I think that's probably our biggest barrier. Our DA is very supportive of drug take-back, of naloxone, and that's really where it stops. We don't have a drug court in Lehigh County. I think there are a lot of barriers there. So they actually have a little bit, there's sort of a work group that meets in the DA's office weekly to discuss cases, and on a case-by-case basis to talk about helping individuals who are struggling with legal issues. And they do that to prevent themselves from needing to have a drug court. So I'm trying to learn more about that, and I'm trying to get invited to those meetings. So I have a phone call set up to I'm kind of trying to weasel my way in, but I think once they find out what my point of view is, I'll probably get kicked out. But I'm trying to get a seat at the table to learn more and try to figure out how we can sort through this. But the DA, I think is our biggest barrier right now.
You know that in Lehigh County, the DA is up for re-election this year.
Yeah. Hey guys.
I know.
So, can you hear me?
Yeah.
Yep. So last May, actually no, I think it was end of 2017. I created these little kits, and I know I've shown them to a few people. And this is a start of what harm reduction could possibly be approved in the area to look like. And the holdback. So I presented it to the county. The county is unable to fund them because of the condoms that are inside of them. But in them, it's clean cotton, alcohol swabs, skin protectant, petroleum, like what is in them. But most importantly is the entire county's like agencies of how to access mental health treatment, as well as drug and alcohol treatment, whether it's prevention, inpatient, and testing for the reduction of HIV, hepatitis, and the other communicable diseases that come right along with the drug use. And then in there is also instructions on how to actually wear a condom, how to clean their needles, and I don't know if you guys can see, and then a copy of the standing order of Naloxone. And everyone that sees it, they're like, we love it, it's amazing, and it only costs to put together a couple dollars. But the resistance was only from the county. Everybody else was kind of like, oh, we'll wait until somebody funds it, until it gets out into the hands of the clients and the patients. Nobody's really going to see much of it, but it is something that, like I said, I mean, I called it Prevention 101. It's already registered. It's already started. Like the little kits are the size of a photograph. So if you guys can see, they fit in anyone's pocket. The goal will be to place them in restrooms. I wanted to take away the part of placing them in a basket in a waiting room where people feel that they're being watched, grabbing them, instead placing them in an area where it's private, that it doesn't matter if they grab one or if they grab 50. If you're going to use them, take them. But I think it would be great if it's something that can be utilized in even smaller settings to start and get presented, and we can make it available to our clients. I know Mars wanted to make it available, but again, it was then having to remove this from the county because those higher ups in the county don't want condoms being given out. So it doesn't, that part doesn't make sense. But if we pull this out, then we're not giving them the information that they need to access treatment, which is the whole purpose of it. So I would love it if we could, have some sort of discussion about them. Hopefully we can get them into the hands of more people and get the information in their hands, get the condoms in their hands, get the Naloxone stand order, and just let them know that there are ways that they could clean their needles, that maybe we cannot provide them a new one, but at least show them how. They have it in front of them, and hopefully we can provide more harm reduction available to those that are struggling right now.
I think that's a great example of creative thinking of harm reduction at a policy level too. How do we, if we can't do the thing we want,
right,
how do we do the next thing? So those are some great ideas there, and I think some beginnings of some terrific conversations or continuation of some conversations. Maybe you guys can start thinking together a little bit too, and I think helping Lehigh County understand what's been successful in Northampton County and the other way around is always our dilemma in the Lehigh Valley. I'm sure that's true out there in Schuylkill and Berks County too. Any other thoughts before we move to a case with our pinch hitter, Jasmine?
Yes, actually, this is Christine Higgins. Can you guys hear me?
Yes.
Awesome. So, so just through that, I was just kind of brainstorming on my own here. And one of the things I'm looking to do for the Wellness Recovery team is to put together some welcome packages. So yeah, Melissa, I think that maybe you and I should put our heads together and maybe we can get something together for me to include some of those things in my welcome packets. Like bags, I should say. I was just going to put together just a little, something with, some first aid stuff, a little bit of, the mental health cards where it has all the numbers on it, a little bit of prevention type stuff. So that I think would be a great idea. And I would also like to continue conversations as to how the Wellness Recovery team can kind of get some of this information across. We do a lot of education in what we do. So I think that we can probably use some education ourselves in order to best get this information to the population it needs to go to. I actually currently do have somebody that we just took on. He's so brand new, I don't know even enough about him yet. But he's homeless. I'm not sure exactly which drugs he is using, but he is currently using but also selling. And, this is kind of a little bit of a new area for us. We have not, luckily, I guess, to some degree for the population we serve, but we have not come across too many people who have been actively using anything more than maybe marijuana. So I think that it would help for us to get some more education for the group to start with, but also maybe come up with some sort of a curriculum, for lack of a better word, that we can utilize and do it very uniformly with each person that we come across. So we're using the same thing each time. And I think maybe doing some sort of joint project on that so that we can kind of be doing our part from the community standpoint too.
Absolutely. Since I presented it last year at the Rally in the Valley, that motivated the intake unit to create a similar thing that you're mentioning. So they provide just little bags with, like you said, like first aid kit information, as well as a few of the things that were part of the kit that I presented to them. So it's definitely an idea that it's there, it's for everyone to use, and we can definitely collaborate on incorporating some of those things and what would be necessary. And then, of course, like you said, getting the providers some education, and Abby did mention it earlier, the importance of allowing us to have been in the drug and alcohol field and working hand in hand with those seeking recovery, the information that we have and how we can help you provide that to your patients.
Great.
That would be wonderful. So I would really like to further that. Obviously not at this moment, but I would really like to further that conversation and come up with a really good plan so that, the more integrated this gets and the more we all work together, I think the more effective we can be.
Absolutely.
Awesome. Clearly a lot of really good thoughts about how do we start coming together for some harm reduction. I'm going to check ahead into some of the further presentations and see if there's more of a place to talk about stigma. I know, Jillian, you had written a whole thing about stigma and how do we decrease stigma, particularly in our health systems, but I think still in our treatment and recovery programs too, with the language we use and so on. So lots to talk about harm reduction and reducing stigma and how do we reach out to the communities that need us the most. So thank you all for chiming in and having some great stuff to say. And I'm getting a little message here that there are a couple of new people who joined in. So we'll ask you guys to introduce yourselves. Star, you can take care of that. And then we'll move to our presentation. It's a case that was provided to us by our partners at Mars, but they're not able to present the case. So Jasmine's going to do it for them. But first, let's do the three introductions. So I guess I'll ask for those. One is the person who's labeled AP0386. Who are you? Introduce yourself. Welcome.
Ring. I'm just thinking, 'cause it's got appointment with me tomorrow, but I gave him 2 days worth. He shouldn't be using it really every 4 hours at this point.
I don't see any accidents out there.
Okay, who is U15611? Or the phone number 610-432-7693?
Hi, Abby. It's Shelly.
Hi, Shelly. For STARS benefit, can you do first and last name and your agency? Glad you're here.
Sure. Shelly Steiner from the COE up at Treatment Trends.
All right, that's great. Welcome. Jasmine.
Hi, Abby. Sorry for the delay. This is U15611. That's how my computer logged me in. My name's Joseph Gingrich. I'm from Reading Hospital. I'm currently in the role of Operations Resource Manager for the facility.
Any response from AP0386?
Right. Let me get here. Bye.
Okay, let's have everybody just make sure you're on mute, and Jasmine, you're up with the case. You ready?
Okay, let me unmute myself, and I think, can everyone see it? We're good? Okay. So, again, so this is a individual that is from Mars, Mid-Atlantic Rehabilitation Services, not Mars Planet. Okay, so he's a 38-year-old Hispanic male and in search of help with non-medication treatment. So that's kind of like our focus for today. He's not aware of the presentation, and he did not help develop the question. So for strengths, we have that he's responsible, he is social and has good communication skills, and he's very family oriented. For history and support, he was initially admitted to Mid-Atlantic Rehabilitation Services in Bethlehem on 8/17/2017, and then he tested positive for heroin at a probation meeting, so he was then readmitted after completing a detox on September 28th of 2018. He has 2 daughters who he has limited contact with, and he works full-time and has limited social support. For housing, he's independent, and he has his own place to stay. Education, he completed a GED. He has some legal involvement with state parole from back in 2013, aggravated assault and disarming a police officer, and he has full-time employment right now. For substance use history, first date of use was when he was 18 years old, and he states that he uses nasally, he doesn't inject IV. For oral forms of opiates, his first date of use was 38, so just recently. A couple, like before he started treatment with us, it was one of those things that for marijuana, first date of use was when he was 9 with heavy use, and then alcohol, first date of use was 13 years old, and last date of use was 2011. And tobacco, first date of use was 18 years old, and currently he smokes every day. So he's current daily use, and it's something that we've discussed, and it's one of his goals to quit at some point. For comorbidities, so medical and behavioral comorbidities, so opioid use disorder, cannabis dependence, major depression, type 2 diabetes. He has a history of head injury. He has hypercholesterolemia, so high cholesterol, and he has a heart condition. of which I don't know the specific for it. But if I have a chance, I'd probably go look at his chart and see what it was. For medications, he takes Suboxone 16 milligrams a day, so 2/8, which he has been on it for a couple of months now, and he states that he's been doing okay with it. And it's been helping with his craving and his withdrawals, and he hasn't used in the last 5 months. Lisinopril and Lodipine, that's for hypertension, the metformin, and the Januvia at the bottom there are for his diabetes. Mental health meds, we have Seroquel, Abilify, and Lexapro. Those are probably easier names to recognize them by, but quetiapine, aripiprazole, and escitalopram, and then trazodone. For past behavioral health treatment, community supports, and medications for relapse prevention. In 1998, he was hospitalized. He was 14 years old. He threatened to kill his mother, his brother, and then commit suicide at the same time. So some SI and HI there. He had a suicide attempt at 14 as well. He overdosed with pills. He's attending group counseling at Mid-Atlantic Rehabilitation Services at Mars, and then he started MAT, being on Suboxone and receiving care management from us at NHCLV in 2018, so just last year. And right now, we just recently placed a referral back in January, I saw, for Haven House for psych services and mental health management, because he does have some auditory hallucinations that he experiences, especially more in the PM hours that he's a little bit worried about. We did recently switch him to Abilify, which he states that was helpful, and he has been able to get more sleep because he doesn't hear the voices as much. For motivation, he has legal stipulation, so he feels like he definitely needs to do it. And then he also has family as a really big motivation for him, relationship with his girlfriend and his daughter. For proposed diagnosis, again, opioid use disorder, cannabis dependence, type 2 diabetes, major depression. I added the auditory hallucination on there. Head injury, the high cholesterol, and the heart condition. For identified goals, so we want to recognize the unhealthy patterns that he has with relationships, because relationships mean a lot to him, so he wants to make sure that he can keep them stable and manage them. We also want to explore feelings of guilt and the negative emotions that he continues to experience regarding his mother's death in the past, and then also to manage his behavioral health and engaging with Haven House. Definitely one of his goals right now. So that's something that we're working with him now. I saw him for a couple visits. I'm not sure if Yamalisa or Cindy, if you have anything to add regarding that, but you can add it right there before we go into peer summarization.
Not sure if Cindy has more current information. I work at Mars, so I have access to this client. I actually completed his assessment, and just looking through, seeing his last individual session, it seems that his home environment is very volatile, so that may be some of the issues as well, aside from the mental health and seeking stability. So aside from that, I don't see anything else stand out other than the fact that he has missed his last 2 scheduled sessions, which could also be affecting his.
Was it 1? How many? I'm sorry.
I saw 2.
2? Okay.
Not sure if Cindy has anything else. If not, then we can move on.
Okay. Abby, would you like to summarize?
Hello?
Oh, Cindy?
Hi, this is Cindy.
Hey.
Yes, I am the Hispanic program supervisor or coordinator at Mars. I am familiar with the case. However, this case is currently assigned to Jenny, and he wanted to present, but she's not able to do so today. So one of the main reasons why I thought that this case was a good case to present is because I feel he started with us actually in August 2017, and he was referred by the CCC. He successfully completed treatment, but probably a month after he relapsed. So we're going in about 2 years working with case, and I feel we have addressed almost all areas with the case when it comes to CRS, MAT, group support, and it seems the client it's not progressing. We have worked on a harm reduction approach with him, and pretty much strength and evidence-based strategies for him to stay sober, but we're not sure how we can continue supporting his recovery and how stable mentally he is at this time. So I'm almost sure there's a lot we can talk about the case, but for the presentation, I think pretty much the main goal is to see how we can come with other strategies probably we have not tried with the client at this point.
Okay, thank you. Abby, would you like to summarize what we just discussed?
Yeah, the last comments were really helpful. Thank you. But we've got a 38-year-old gentleman who's got a long and complicated psychiatric history, including some homicidal and suicidal ideation and a suicide attempt at the age of 14, who came into treatment about a year and a half ago with an opiate use disorder and some history of polysubstance abuse. And in the intervening time has had some flare-ups of his mental health issues with major depression and psychotic features, and was referred back to care with a relapse. And the question is, how do we support his recovery when we feel that we've tried all the tools in our toolkit and there still seems to be a long way to go? Is that about right?
I would say so. We got a thumbs up from you and Lisa. So great.
And Cindy. Great. Yeah. So let's start with just clarifying questions from the group. We'll try and stay away from too many suggestions until our second round. But clarifying questions. What are more things that we want to know? And for some folks who are part of our hub here and are representing a particular role, case, and let's see what kind of questions we can serve.
Hi, it's Christine Higgins. So I know that you said he is getting, I'm guessing, psych med management at Haven House. Is he getting any other services through Haven House? Because they do have an array of services.
So I think we placed a referral. I'm not sure if he actually engaged. So right now we're just managing. We started him on some medications at neighborhood health centers like the Abilify, the Seroquel. I think the Seroquel he was already on it. The Abilify is something that we changed and it did well for him. But regarding medication management, I don't think he's engaged with Haven House yet. But the rest of the other services that they offer, I think they would definitely be a good option for him once he gets engaged.
He does have an appointment. I don't have the date right now, but he does have an appointment. He's symptomatic when it comes to mental health, and I want to say we work in a crisis mode, and we're looking forward for that appointment and to get some input from the evaluation to see pretty much what is the diagnosis, and then we can integrate that in his treatment plan. But at this point, we don't know what is the diagnosis, and he presents different symptoms, such as hallucination, depression, manic, but we don't have a full diagnosis to go by and integrate that with his treatment plan at this point.
Cindy, he's bilingual, right? I've only spoken to him in Spanish, but he speaks English too, right?
Well, it's like most of our clients that decide to join the Hispanic track, they do have understanding, but when it comes to express themselves, to advocate for themselves, it is limited.
Okay.
He can have a conversation. I believe that he will be more comfortable in his native language to express and describe what's going on.
Yeah, that helps to know as we're making suggestions in the second half of this, so that we know what agencies would be appropriate to suggest for him.
asking people from their perspectives. Chris, one of the things that you're representing is our sort of peer support perspective. What kind of clarifying questions would you have for this?
So one of the questions I had was earlier in the presentation, did you say he was seeking a non-medication based treatment? Could you clarify that one component?
That's an option on the case submission form. So some of the options are like you want help with medication management, you want help with non-medication management. So I think that option just means that we want to speak about something that isn't directly involved with medications, but in this case, we're just looking at it overall. Like we want help in keeping him engaged and in supporting him.
Okay, I just wanted to clarify that. Cindy, what were some of the goals? You said he did work with the CRS. I'm assuming a Spanish-speaking CRS, correct?
Yes.
And what were some of the goals, the recovery goals they were working toward?
It was more of the stability piece. Once he left the CCC, we were able to place him at Victory House.
Mm-hmm.
He used and was discharged. Then he was homeless. And he was pretty much going to be sent back to jail, but a lot happened to that. So one of the goals is for him to obtain an ID. That has been a birth certificate. So that has limited him to do a lot of other things. At this point, I know that we have tried, including the CRS, everything we can for him to obtain that, but specifically the birth certificate from Puerto Rico,
mm-hmm.
and consequently an ID here. But he's not doing the part that he needs to do outside the office.
Has he engaged in any type of pathway to recovery, like 12-step, like anything like that that's actually engaged him?
Yes, he did engage in NA meetings at Mars in Spanish,
mm-hmm.
and he was engaged. But like I said, when he becomes symptomatic, he stopped doing all the things that are helpful for his recovery. So he was engaged in NA meeting. He had a CRS, and he had someone who was in recovery who was like a mentor for him as well, and he had that support.
So was that the extent of his peer support network, the CRS, and this other peer that you mentioned just now, or did he have others?
Church.
Church.
He became,
okay.
Yes, church. However, there's a big question about his motivation to attend church because his girlfriend does go to church often. So one of the treatment issues is the codependency when it comes to relationships. The client have always engaged in a relationship, and whatever it's going on with the partner, that's what he tends to follow. And then when they have a disagreement, he tends to then go into he becomes symptomatic in the hospital. He just don't know how to function, whether with the drugs or the substance or with the relationship. Okay. And I think one important factor here is that he's at pre-contemplation, although he's doing everything we require for him to do, and he appears motivated. When it comes to his opiate use or dependency, he does not feel he has a problem. He does know he relies on that when he feels very depressed, but he has never played himself. And I think that's the stigma that comes with the culture too.
Mm-hmm.
Although it is an oxymoron because he is going to neighborhood center. He does go to treatment, but when I do supervision with Jenny about the case, he does not and is very evasive about addressing the fact that there is a opiate dependency here, and everything else, it's a consequence of his inability to stay sober for X amount of time.
What's his acceptance with his mental health? Or is there any?
There is a level of denial. He feels it's directly related to relationships.
Okay. So he's more open to accepting the addiction part than the mental health part?
I think vice versa.
Oh, vice versa. Okay.
I think I think it's a crutch in a way for him to justify certain behaviors in his inability to pursue the things that are important for him in order to become stable, and rely on it's because of my mental health, which is true, which is there's something going on there, but he's more open to talk about that based on what I hear from Jenny, because I haven't interact directly with the client in a while, but during supervision, he does not address the substance abuse. He does what he knows he needs to do, although he also does not want to go to jail. So there is some external motivation. He's on state parole, and he's facing a lot of time, and he don't comply. So to answer your question, Chris, based from what I gather, I believe he's more willing to accept the fact that he's symptomatic and his mental health deteriorates sometimes than to say I do have a substance abuse problem, and everything else probably is related to that.
Gotcha. Thank you.
You're welcome.
I'll wait till suggestions now. Thank you, Abby.
Bill, do you have any suggestions from a counseling, drug and alcohol counseling?
Just a couple of questions here. Has there been any period where he has done well?
That is a very good question. I want to say that when he, and when it comes to time, I want to say the reason why he was discharged July 2018 from Mars because he appeared to be stable at that time. Okay.
Thank you for holding. We'll be with you momentarily.
Can you guys hear me? Okay.
Yeah.
So at that time, he had a full independent housing. He was able to find an apartment. He was engaged in church. He had the CRS. He was exploring the NA option. He resumed a relationship with some of his family, his daughters. So things were going well for the client at that time, and he was stable enough to be discharged after a year of complying and doing very good. But like I said, it only lasted about 2 months, and then he relapsed and gave a positive to state parole on heroin.
Okay. And assuming, is he at all, what's his kind of rate of, or his level of compliance with his medications?
There is no medication at this time. And one of the barriers was that he did not have medical, and the county funded his substance abuse treatment, and we attempt for the county to fund his mental health, but there's no ID. The only ID he had, I believe it was from jail. So that was a barrier for quite a while. And I mean, I'm trying to, and again, remember that this is not my personal case when it comes to medication. I know during the past couple of supervision, that has been the focus to get him engaged. And because he's attended neighborhood center, I believe through Gina, because we do meet once a month, neighborhood was able to help us to engage him with an appointment. And that's where the Haven House mental health appointment, it's coming in place.
Okay, thank you.
Jillian, do you have any questions from a addiction specialist point of view?
I don't think so. I'm just sort of wrapping my head around the case. Very challenging situation, and I think a common one. So yeah, no further questions. I am interested in when we get to the suggestion part of this to hear what our colleagues think.
This is Christine again. I do have one more question. Were there any differences noted as to what was going on, whether it be in his life and his relationships, while he was doing well compared to when he started to relapse? Is there any noted changes that we can kind of attribute the behaviors may be coming from?
My opinion, it's that the honeymoon was over, and then he started to just go through normal relationship dilemmas, and his coping skills to deal with just life itself are very limited. And based on because I remember seeing him, and I'm like, what happened? His brother died in Puerto Rico, and he felt responsible for his death. I believe the brother started, this was a brother, and then when I inquired a little more, was not related, but there was an emotional connection, and he introduced this person to the criminality world, which is also part of the client past, and he felt some type of shame and blame for that, but he also attributed to having some relationship conflicts, and that seems to be the main topic in almost every session. He just wants to just revolve around the relationship and all the chaos that goes around within.
Has anybody suggested, well, I guess this would be suggestions portion, so I guess I'll hold off on that.
Well done. I have a question about, what do we know about his adverse childhood experiences and what might have been going on when he was 14?
Dad was an alcoholic. There was a lot of violence in the house. Mom was mentally ill. Cannot recall the diagnosis right now, but he's the older brother, and once mom passed away, and either dad passed away first or mom did. I know it was very close together. They both passed away. He became in charge of his sister and brother, and then he started dealing in the street, and very dysfunctional upbringing based on what he stated, and a lot of violence, physically and emotionally.
Anybody else have any further clarifying questions? It's gotten to be quite a rich case. All right, the moment you've all been waiting for. We can go for a round of suggestions.
All right.
I guess I'll start since nobody else spoke. It's Christine. So one of the things that I was going to ask, has anybody spoke with him about maybe like relocating, even if it's not like totally out of the area, but sometimes that change of scenery does play a part too. And on the other hand of that too, if there's a lot of relationship issues, has he been spoken to about, you know, how detrimental having a relationship like that can be to his sobriety? And has he been receptive to, you know, taking some time for himself, I guess you could say?
Relocation, he's on state parole, so it's limited. He does live independently. He's renting a room, so it's just a matter, either he'll live Allentown or Bethlehem. I don't think we can geographic location more than that. It doesn't seem that the immediate environment, it's a trigger. Probably loneliness might be a trigger for him, but nothing that it will be a drastic moving him from one place to another right now. And I know where he lives, based on the conversations I had with him, and I know where the area is. It's not drug infected, so it seems that that's a good location for him. When it comes to relationship, and I'm going to go back probably when he was, I worked directly with him. We did went over codependency, and how when we have significant losses in our life, we develop dysfunctional attachments. So he is able to process the information in session and expand on it and have an understanding. However, his actions are incongruent with what he says or what he's able to process, which is common with our clients.
Yeah, absolutely. I think to that, my suggestion would be something community-based. I mean, obviously coming from a community-based person, but one of the things that I try to stress with our behavioral health navigators is to make sure you connect with the therapist to see what they're working on, because knowing it in theory is one thing, putting into practice is a completely different thing, and that connection is not always there. And that's one area that we can make an impact, is to help them to make that connection so that they can put those theories into practice in their everyday life. You know, granted, obviously that's not an overnight thing, and they've got to be receptive to it as well. And, you know, we all encounter people who are and aren't. So hopefully he would be more receptive with that. I know one of the struggles right now, considering he, while is bilingual, would be more comfortable with his native language. I think the availability of that right now is very limited. I know that I have lost the one bilingual staff that I had. I did lose her. So right now, by the way, just public service announcement, we are looking for an RN for our team. So please put the word out, preferably bilingual. With that being said, I believe Haven House also struggles with that with their wellness recovery team as well. However, we are looking at alternative options. So we are not opposed to at least giving it a try. We have been using an app that has been helping us somewhat. So far has worked pretty well. I think some of the more technical medical terms it struggles with, but for everyday conversation, it's been pretty useful. I don't know if he would be open to giving that a go, but that may be a good option.
Thanks.
Questions, Chris? I know you were brimming.
Did you say Chris? Sorry, well, I was brimming because I have two puppies here at my legs, but no, I did have some thoughts to share as well. Sorry. So it sounds like from the recovery standpoint, a good solid plan was put forward. Everything that you would want to address with this individual has been. Personally, what I see is from a recovery standpoint, that's not allowing him to connect the concepts. Is it just sounds like there's a whole lot of untreated mental health at this point. And that untreated trauma that Cindy referred to in his adolescence still is when that meets the stigma from a cultural standpoint that he faces, and that I understand that well too, that there's some cultural implications from my standpoint that I've seen as well in that, and that can be the barrier in itself to help make this next level connection that you need to make these recovery concepts. I think what's paramount at this point more than anything is going to be the mental health component when he actually does get into Haven House and can start making progress that way. Then a CRS in their sessions and talking about and someone I don't know if it was Christine that mentioned implementing the coping strategies, that then a CRS can help probably relate and role model how that's worked for them. But right now it sounds like there's just a lack of the appropriate knowledge and what he needs to process some things. That's what I would say at this point, and why the strategies that have been applied before probably weren't as successful as one would hope.
I agree. I think the other thing that that I kept hearing too is about the guilt that he's feeling, and guilt alone can play a huge part on mental health and even the choices that we make, because we get very blinded by guilt. Generally, it doesn't even have to be somebody who is suffering with anything outside of that. So I don't know. I know he's receiving therapy, but is the therapy he's receiving, is that more so aimed at addictions, or is it including the mental health and some of that stuff? Are there maybe more specific therapies that he can be receiving to address some of those issues?
When I sat down with his counselor, we revised the current treatment plan, and and whether that was formulated completely by him or her input and what happened. And what I suggested her was that our main goal in that treatment plan is just mental health stability, because we're just going to keep going, just merry-go-round with him. It seems like we just stay in the same place. And because we don't know if this is direct, which I really think, like Chris says, I think that his mental health, it's the bigger obstacle right now to progress with him in treatment. Although I have to say he's compliant. When he does not show, he does call. I think when he gets into a psychotropic regimen, if that is prescribed, and so one can address that other mental health obstacles, then Jenny can suggest to him if he's willing to start working on his self-esteem and self-worth, and just know who he is as a person today. I think instead of just focusing on the external of the relationship, that's just a symptom of something bigger, which is his own probably lack of a lot of things. Again, self-worth, self-esteem, who I am, the denial part, how probably because he has been dealing with the consequence of his addiction, he's not able to choose a partner based on love, trust, and other quality. He's pretty much just choosing a partner not to feel lonely. So then we can focus on all that. But because he's not stable enough, I think the treatment plan has to remain as just mental health stability and a harm reduction plan. Make sure he don't relapse at this point.
I have a question, and it's not a suggestion, but how long can Mars keep working with him, and how intensely can you keep working with him in a harm reduction kind of mode? Do you have any limits on that? He's county funded right now, right? And
no, at this point, I will have to look. I believe he just transitioned to Magellan.
Oh, great.
And I will advocate with the county too. I think if we submit a good ASAM, just to find what he meets criteria for the level of care, which he does, probably for an OP level of care for a long term, and we have all the facts that we can back that up. I don't see the county seeing the facts and a strong ASAM will say no, we won't fund this client. There's no he's a long term client, and specifically with the Hispanic track, we tend to keep them longer because there's so much case management and so much we need to do with them due to the language barrier and lack of resources. So when it comes to time, I'm not that concerned. In the harm reduction at Mars, as treatment providers, we do individualize their treatment. We go strength-based. So with him, until these other things are not in place, we just have to keep a harm reduction plan with him.
Really appreciate that about your organization and that orientation that Mars has, kind of focus on the harm reduction and the connection until somebody's ready to make a move. I think one of the things that I've been hearing about, and I'd love to get some input from the rest of the group, is I think what I was thinking about this case, and one of the real dilemmas for us in primary care is that we have a lot of folks like this who are complicated, and no matter how well we all do to wrap services around him, he's still going to be complicated. He's had a lot of things happen to him. He has physical manifestations in his physical illnesses. He's got a lot to get through. When his treatment is over, there's not a lot out there for us to rely on in terms of recovery support. So I'm curious what other people, let's imagine that that we actually get him to see the psychiatrist at Haven House and he gets on a regimen and that stabilizes a little bit. What kind of long-term support recovery would help this guy? What's out there?
Well, again, from a recovery standpoint, I think the Mars team has done a tremendous job at connecting him with what is actually out there. I think it's really a difference of how he would respond to it, not so much change it, not reinvent anything out there, not so much change it, but how, some of the awareness that maybe he can develop in more mental health focused treatment that can help the CRS, then so he can better see how the CRS is role modeling some of what they're trained to do. And I really think that's the disconnect at this point. It sounds like he's functional. I think it said job-wise, he's full-time, he has full-time employment. So things like that, he is able to do that. It said he had his GED, I believe. Right. So whether there's greater educational aspirations or whatnot that we could start to look at once he becomes a little more emotionally stable, that might be it. But otherwise, I think it's a matter of, revisiting a lot of what seems to be things that he could connect that at different points. He just couldn't bring it all together because he wasn't stable enough at that point, or it still isn't. But it's just, it may connect differently with the addition of the more mental health focused treatment.
Sorry.
No, go ahead. You can respond first. I can wait.
No, I just want to say that I'm revising the curriculum for the OP and the IOP with the Hispanic track. And one topic I'm looking forward to integrate is acculturation. And I believe once they complete treatment, there's very limited resources for them. And I'm meaning for the monolingual clients specifically, the ones that really don't speak the language and probably they will not speak the language the way it's required due to either cognitive, long history of substance use. It's just not, they can't. It's a matter of not be able to do so more than not wanting to do so. And I think that is important to differentiate. But just the acculturation part, because what I see some of them, and then with this particular client, he still speak as he is back in the island in Puerto Rico. And because when they go to group, they feel that bonding. They can speak their language. They understand their values. They look like each other. Once treatment is gone, there's not really a place for them because they don't belong in society. So they feel either there is a criminal record, there's the stigma that comes with addiction, but there's also not really a place when it comes to recovery either. So they stay kind of in the limbo, and any little crisis, they don't know where to go, what to do. So just implementing that acculturation piece, I think it will help them transition and assimilate the main culture and be like, well, things are different in America, and I will need to develop this here because it's not going to work any other way.
So just out of curiosity, has he expressed any long-term goals, be it like in the area of career, education, that kind of thing, like what he wants out of his life in the long run? And maybe that's something that can be used as a motivational factor, and maybe within those goals, we might be able to find other supports.
He wants to be, believe it or not, and I think he will be great, because if you meet this client, he is extremely social, happy, outgoing person, always have a story. He would like to be a CRS. That's really where he sees, and I'm like, that's your 12th step. You have to stay involved. There's no other way to do this. If you detach from this world, it's probably not going to work. But again, there's the barrier. And even because I know I spoke with Chris about this probably like a year ago, at some point offering the class in their native language, they still need to take the state board in English test. So we can explore. That's a very good question. What are some of his new goals, and see how we can support him. But he had expressed that in the past when he graduated. He really would like to be a CRS.
Just kind of thinking in that respect, I wonder if psych rehab services may be a help in the motivating factor, because they can work on goals even outside of just his. I mean, obviously he needs the treatment, the treatment teams involved. But maybe giving them something outside of that may help the motivation side of it.
I think that's a wonderful spot to wrap up on, and a little bit of a hopeful note. I think it's great to be able to have these conversations so that we can think about how to coordinate services and what does this guy in particular need, and how do we as a community come around to support some of his mental health and social needs. So great case. Think about the cases that all of you have that you might want to bring forward. I know one of our residents, Jillian, was talking about a case that he saw with you of a woman who had overdosed in the ER in her 60s. But let's have everybody think about cases that you might want to present. If you're just thinking and you need a little encouragement, Jasmine's there for you. She can mold it into something presentable and make it fun. Our student friends, you are also welcome to present a case. So that's my pitch. Think of cases, bring them forward. The more we have to talk about, the more exciting this gets. Our next echo is on the 26th, 2 weeks from today, and we will see you then. Thanks for joining us on this yucky day.
Thank you, everyone.
Yeah.
Bye.
Bye.
Bye, everyone. Enjoy the snow.
Wait, I have to turn this off and off. Finish it? No, maybe highlight.